Chapter 10 is going to be on the clinical decision-making for periodontal care. We're going to start with section 1, which is going to be guidelines for arriving at periodontal diagnosis. So a clinical decision-making is the process whereby all members of the dental team use the information gathered during the comprehensive periodontal assessment to arrive at an appropriate diagnosis and identify treatment strategies that meet the individual needs of the patient. So we gather the information, we evaluate all of that information, and then we come up with a treatment plan. So fundamental diagnostic questions. Does the clinical assessment indicate periodontal health or inflammatory disease in the periodontium? So are they healthy or do they have a disease of some type? If the clinical assessment indicates inflammatory disease, is that disease gingivitis or periodontitis? And if the patient has gingivitis, what type of gingivitis is it? Is it chronic or is it acute? And if the patient has periodontitis, what type of periodontitis is it? Is it stage 1, stage 2, and on and on? So here are how those questions could be kind of flow charted out. Does the clinical assessment indicate health or disease? If they're healthy, that's the end. If they have disease indications, then is it gingivitis or periodontitis? And you go into the prospective category and then what type. So question 1, does the clinical assessment indicate health or disease? If there's healthy, no need for further diagnostic decisions. If it is disease, further diagnostic decisions will need to be made. So health or disease. The decision should be based on the signs of inflammation. Often in dental hygiene, we talk about the signs and symptoms, right? Well, signs of disease are observed and can be measured by the clinician, okay? These are objective, right? We see changes in the color, contour, consistency of the tissue. When it comes to symptoms, however, these are things that are noted by the patient. Symptoms are not something that we as the clinician will identify. We can ask the patient and they can tell us of the symptoms, but we would not be able to identify them without the patient saying so. Symptoms are something that, while we take them into account as far as our treatment planning goes, they're not what we use to determine disease states. So when it comes to signs of disease, those visible signs are going to be changes in the color, contour, and consistency. This is, these things go together, right? We've been talking about this for a while. When it comes to the hidden signs, things like bone loss, exudate, and bleeding on probing, these are not things you're going to be able to just look into the patient's mouth and see. You have to do a little bit more digging. So question 2, is the disease gingivitis or periodontitis? In other words, is there attachment loss or is there no attachment loss? And bone loss. We're looking at x-rays. So what type of gingivitis or what type of periodontitis? So we might classify the gingivitis, classify periodontal disease, or not, it shouldn't say periodontal disease, should it? It should say periodontitis. And keeping with the last chapter in chapter 9, we're going to classify peri-implant disease and conditions as well. Flexibility. So it's important to remember that we don't just put someone in a category. There has to be a lot of flexibility when it comes to assigning that periodontal diagnosis, because sometimes more than one diagnosis might be made in each patient. They might have, generalized healthy but localized gingivitis, or they might have localized gingivitis and generalized gingivitis and localized periodontitis. So it's important that we don't just say one when we're talking about a couple of different characteristics or a couple of different diagnoses. As far as documentation goes, this is a critical skill for the dental team, especially for a hygienist, in order to maintain our licensure and to be able to have consistency throughout our patient's treatment. We want to adhere to a standard format for documentation. We want to use the right terms in order to be able to describe what we're seeing, so that next time when we look at the tissue, we're able to determine, is this different, is it better, or is it worse, or is it the same? And then also as well, we want to be able to communicate with other dental care professionals and be able to understand exactly what they mean when they say what they're talking about. So we're going to include those descriptive modifiers that describe the severity and the extent of the disease. When the disease state, this is a multidimensional staging system, which we talked about in, chapter 4. Staging identifies the severity, the complexity of the management, and the extent of or the distribution of the disease. When it comes to the disease stage, stage 1 is going to be initial periodontitis. And remember, we don't stage patients who are not in periodontitis, right? So healthy and gingivitis, when they don't have attachment loss, they don't get staged. For the purpose of our clinic, yes, they get a stage 0 because we have to be consistent in the way that we, track graduation requirements. But as far as like real periodontal conditions, we don't stage patients who don't have clinical attachment loss, only when they do. So stage 1, initial, stage 2, moderate, stage 3, severe with the potential for tooth loss. And then for stage 4 is going to be advanced or severe with extensive tooth loss and the potential for the loss of dentition. When it comes to grading, so this is used as an indicator of anticipated rate of progression for the periodontal disease. Again, grade A is a slow rate of progression, B is a moderate rate, and C is a rapid rate. Disease extent. So here we're going to be using descriptive modifiers as to the extent of the disease. So here we will be using localized, generalized. Another sort of terms that you can use are molar or incisor. Most often in our clinic we'll use things like posterior or anterior to describe this kind of patterns. So modifiers here, we have the descriptive modifier as far as the stage. We have the stage that we have, and we can use those initial, moderate, severe, or advanced. Those can easily replace the words, stage 1, 2, or 3. And then disease grading, so we can put the words slow progression, moderate progression, or rapid progression, but it's just easier for us if we kind of keep the grade A, B, and C. And then extent, so we want to say how much involvement is there. If it is localized, it must be less than 30% of the teeth. If it's generalized, it's more than 30%. And if it's only seen in the molars or if it's only seen in the incisors, you can put that molar incisor, you can put like molar pattern or incisor pattern, or like how most hygienists will write things is posterior or anterior. Examples of a diagnosis might be localized stage 1, grade A, periodontitis, localized stage 3, grade C, periodontitis, on and on. So the case type system for the periodontal patients is going to be limited in value. So here we're talking about the old case types. This is on page 191 in your book. Because they didn't allow for a lot of sort of nuance to the way that we classified the patients, it's limited. However, some insurances will still need you to put this type of verbiage into things, so it's a good idea to kind of have an idea of what this is, but it's not the best method. So it's limited in the value, and it has been standard practice in the United States for many years now. Since 1999, they've been using this case type system. It's used in reports to insurance companies, and the case type alone does not specify the precise periodontal disease classification. So when it comes to like case type, it's hard to determine, just because you're a case type 2 doesn't mean you necessarily need SCRP. What if you just need a perio maintenance? So it can be kind of difficult to use this. But what that basically is case type 1 is gingivitis only, case type 2 is mild periodontitis, case type 3, moderate, case type 4 is severe, and each one of those has a certain percentage of bone loss or certain millimeters of bone loss that would indicate the transition from one case type to another. Moving on to section 2, the guidelines for periodontal treatment sequencing. Here we're going to be talking about how do we go about choosing what type of treatment our patients need. So periodontal master treatment plan is a sequential outline of measures to be carried out by the dentist, hygienist, and the patient. It's going to be to eliminate the disease and to restore a healthy periodontal environment. It's going to coordinate and sequence all of their treatment and education. So at what point do we give patients oral hygiene and instructions? At what point do we refer our patients to a periodontist? That kind of thing. It's going to estimate the length of time required for comprehensive treatment. So how many appointments is this going to take? Those are the kinds of questions our patients are going to ask us, and we need to be able to answer them. We're going to communicate with our patient. That is absolutely vital. We have to keep the patient involved, and ultimately, the patient has to consent for this treatment. So if we don't explain it thoroughly to them, they can't consent. So we won't have informed consent. As far as the 5 stages of periodontal treatment plan, it's going to go in this manner. So first we're going to assess and the preliminary therapy phase, and then we'll move to non-surgical periodontal therapy, phase 1, surgical therapy, phase 2, restorative is 3, and periodontal maintenance is phase 4. Did I say stage in the previous one? I meant phase. So anyway, in the assessment and preliminary therapy, this one is kind of before we start to deal with periodontal treatment. And in this one, we're going to be collecting all of that data. We're going to be, taking radiographs. We're going to be doing our perio charting and our perio or gingival evaluation, right? We're going to be collecting that information, and we're going to care for their immediate treatment needs. So if they have any emergency dental care, like they have a toothache of some kind, they need a root canal of some kind, if they need to have teeth extracted either due to cavities or if they have hopeless teeth where their bone loss is so severe that there's no chance that the tooth will be saved, it's not a good idea to try to do SERP on a tooth that's totally hopeless. It's a waste of everyone's time, right? So we would probably extract those teeth before beginning this therapy. And then a comprehensive clinical periodontal assessment. So in this one, we're going through all of those areas and we're evaluating, is it localized, generalized, and that kind of thing. And then this stage is also referred to as emergency therapy. Basically, this stage is, does the patient have any chief complaint or chief concern? I typically hate the word complaint because I don't think that my patients are whining. I think that they have concerns, and I think that that's a bit more of a appropriate verbiage for this. But anyway, so if they have any chief concerns, this is where those types of things get addressed. If they have pain, if they have hopeless teeth, or if they have any concerns that they need education for, we give that to them in this stage, or phase, sorry, I keep saying stage. So in phase 1, that's going to be non-surgical periodontal therapy. This is where dental hygienists reign supreme. And so we're going to be providing non-surgical measures that will help control gingivitis and periodontitis, which include periodontal instrumentation, which is periodontal instrumentation is going to be both the use of Cabotron and hand scale and all of that good stuff. And then dental hygiene care and educational measures. So we're going to be providing care for them while also trying to teach them how to stop their bad habits and start good habits. And then we're also going to be performing bacterial control and anti-infective therapy. Infective looks funny. Maybe it's just because it's in all caps, but I feel like that might be misspelled. Anyway, so it's called bacterial control and anti-infective therapy. Things like, oral rinses, oral irrigations, localized antibiotics, things like that. Those are going to be that sort of stage. And then phase 2, this is going to be surgical therapy. So if the patients come in for us and we perform non-surgical therapy on them and it is not successful, the pockets don't heal or things start to get worse, it's time to refer them over to a periodontist. Or ultimately, the patient comes in and they are beyond our scope maybe we're working in a general practice and they're too involved periodontally. And so we need to refer them to a periodontist to get that periodontal surgery first. That way they're not spending a ton of time and money trying to get treatment through a general practice when they might be better served just going straight to a periodontist. Every time you see a patient, even in our clinic, when their case is so advanced that it's probably not a good idea, anything usually 7 millimeters or greater, in general practice, we can't, clean that well deeper than 7 millimeter pockets. So typically, and every dentist is a little different, every office is a little different, but there's usually a pocket depth that's like okay, well, I think you're better off going to a periodontist and having periodontal surgery done, where they, remove part of the tissue. The bone is already resorbed. They clean that area extremely well. They put in grafts. They cover up that area so it can heal, and then they send the patient on their way. Typically, they get better and they come back to you. Also, placement of implants happen in this stage, and root canal therapy. So the number one person who places implants typically is going to be periodontists, because people lose teeth to periodontal disease, so people need to get teeth from periodontists, right? But also oral surgeons can place them, and even sometimes general dentists will place implants. And then root canal therapy as well. If they have an issue that is kind of beyond the scope of a general practice, they get referred out. Stage 3 is restorative therapy. So we do our non-surgical therapy. Hopefully they get better. If not, we send them to the periodontist. And then is when it's time for splinting their teeth, doing restorations, replacing missing teeth with prostheses, a reevaluation of the overall response to treatment here as well. So you don't necessarily want to do a bunch of fillings on teeth that will just end up falling out. So typically in offices, they will prioritize, depending on the patient's requests, offices might prioritize periodontal therapy over the work that needs to be done. And I know in my office, we would do scaling and root planning before they would go and get their fillings. And the reason for that was, first of all, bleeding, right? And overall bacterial load. So we want to reduce that bacterial load as much as we can and reduce the amount of bleeding, so that when my dentist would go in and do his fillings, it was, less of a bloody field. So he would have, better restorations. And we had a better look at whether or not those teeth were going to make it. As far as phase 4 goes, this is periodontal maintenance. Again, dental hygienist reigns supreme here in phase 4. And so here we're looking at ongoing care at specified intervals. Depending on the patient, depending on their needs, is how often we want to bring our patients in. All measures used to keep periodontitis under control. So here we're probably doing periodontal maintenances, or periodically we might be going back for that non-surgical therapies, depending on the patient and the patient's needs. So this phase is used to maintain teeth functioning throughout life. Once they kind of get into periodontal disease, we need to be forever maintaining their periodontal disease and trying to prevent the reoccurrence of disease, trying to, in phase 1, we tried to stop the etiology, right? Whatever was causing the disease. But for perio maintenance, our goal is to prevent it coming back. So here is a flowchart of that. We have patient evaluation, diagnosis, and urgent therapy. And then we get into the phases. So phase 1, non-surgical periodontal therapy. Another name for this phase is initial periodontal therapy. And then we have the reevaluation of results of non-surgical therapy. Obviously, you bring them back and you take a look at them in their re-eval. And then you can have surgical periodontal therapy if the non-surgical didn't work. If they need it, and then you send them over to the restorative therapy with the dentist, and then they send them back for periodontal maintenance. Section 3 is going to be the need for ongoing decision making. So here, the needs change as that person progresses. As that periodontal disease either continues to get worse or it gets better, we need to change not necessarily our diagnosis, but we need to change our treatment plan, right? So if the patient were to come to us and they had 6s and we did non-surgical therapy and they seem to get better, but then a year later they have 7s, well, our non-surgical therapy probably wasn't as effective as we wanted it, or most likely our oral hygiene instructions weren't as effective as we would have hoped they would be. And so it's time to maybe reevaluate and to, send that patient over to a periodontist, or go back through all of your oral hygiene instructions and do non-surgical therapy again. It just depends on the person, what they need, and what's going on with them. So a periodontal diagnosis and plan for therapy at one point in time may require modification at a later date. And it's important to communicate the possibility of change in the plan to the patient. So I do this a lot where I say, you know, this is what I think is going to happen. I think when you come back, we're probably going to see this, but we might not see this. And if that's the case, if, you know, worst case scenario, this could happen. Best case scenario, this is what happens. And we just, you know, play it by ear, see what happens. And if it works out, great. If it doesn't, reevaluate. So when we need to adjust, we might need to adjust because the periodontium is dynamic and continuously changes over time. It is a living, breathing tissue, well, kind of breathing, it breathes through the mouth anyway, and then subject to physiologic tissue remodeling. So the tissue changes and we need to change with it. And it's going to be subject to periodontal destruction throughout the lifetime of the tooth. So, you know, over time, you'll see that your patients either get worse or they get better, and you keep track of them. Clinical decision-making for the treatment planning is going to be ongoing. Therefore, it continues to evolve over time. That's like the third slide that said that now. The main thing, too, that we need to remember in this is that the patient gets a say. So the patient is not only educated about what's going on, they get to have informed consent about whether or not they choose that treatment, and then they are kept in the loop as far as when things evolve, what's going to happen to them. It's pretty important, but that's the end of chapter 10.